Good morning, good afternoon, good evening, colleagues. I would like to share with you the highlights from the scoping review looking into non-surgical options for the management of the neuromuscular scoliosis. I have no conflicts of interest. This scoping review needed a lot of extra search terms because when you look for neuromuscular scoliosis, only you find articles about surgery. So by looking at extra search terms, I did find numerous articles. The neuromuscular scoliosis is different in the sense that it is part of another disorder, and they can be very serious disorders. These disorders present with very different problems. Sometimes it can be spasticity, it can be extreme weakness or pain. We can have thermoregulation issues, malformation of the bones, inability to change your own posture, cognitive difficulties. There are many extra problems. Most of the articles regard the cerebral palsy population, and a number of these are based on the CPUP database. The main thing that came out of these studies on the cerebral palsy children was that the importance of early hip surveillance. So these studies based on the database from Sweden have shown that if you can really look at hip migration early, you can help delay the neuromuscular scoliosis developing. Hip migration looked at an early age from 2 years old on can help stop or reduce the hip migration, keep a nice symmetric pelvis, and not have a scoliosis develop early. The other things that were talked about in the articles are pain, sleeping difficulties, mobility issues, and weakness of the breathing muscles, and the fact that orthotics can be used in cerebral palsy. In Rett syndrome, other issues are the problem, and one of the things that came out of research was the importance of weight bearing. In the Duchenne muscular dystrophy children, data suggests that we need to change posture often to keep that spine mobile and lordotic. Literature looking at the spinal muscular atrophy suggests again that we need to stand a lot, keep these children on their feet in standing frames, and that braces can be used as long as there's enough space for breathing by an opening in the stomach area. What also comes out of these studies is that there's still a lot to be done. Parents are not informed enough, often enough. They don't know enough about the risk of the cardiovascular problems they can get. There's a difficulty in accessing coordinated services in adulthood. If a child has undergone a selective dorsal rhizotomy, the spinal deformities can increase. They really have to be monitored afterwards. And what has been shown to be very effective has been the molded seats in the standing frames. So research is showing that these can really stop or stabilize the hip migration. The other thing that has been shown to be positive is the nighttime positioning. Even in adults, the posture can be changed. And we as therapists need to keep that thorax and spine mobile as long as possible. So mobility of chest wall and spine and pelvis and hips, preventing contractures, looking at the whole fascial chain, and telling patients and parents to keep their children in different sleeping positions, especially when they're not being positioned. So I would like to thank you for your interest. If you have any questions, feel free to email me, and please read my scoping review on ResearchGate. Thank you very much, and I hope you enjoy the rest of this conference.